This is an audio presentation for the Journal of MRI. My name is Kelly Fabrega-Foster, and I will be presenting our study entitled Gadobutrol-Enhanced Renal Artery MRA Study, or GRAMS for short. This study evaluated both the efficacy and safety of Gadobutrol-Enhanced MRA of the renal arteries in patients with suspected renal artery stenosis. In the interest of time, only the efficacy portion of the study will be discussed in this presentation. The purpose of our study was to compare the performance of MRA with 1 molar gadobutrol to 2D time of flight MRA, utilizing CTA as the standard of reference. Our primary objectives were to evaluate for superiority of structural delineation or accessibility of the renal arteries, and to evaluate for non-inferiority for detection and exclusion of clinically significant disease. A number of secondary objectives were also evaluated, including detection of accessory renal arteries, necessity of recommending additional imaging follow-up, presence of artifacts, differentiation of fibromuscular dysplasia from atherosclerotic renal artery stenosis, and diagnostic confidence. However, in the interest of time, only the first two secondary objectives will be discussed in this presentation. With respect to the study design, this was a prospective multicenter open-label study. There were 317 participants enrolled at 55 centers in 13 countries worldwide. 292 participants with suspected renal artery stenosis completed the study. All participants underwent both contrast-enhanced MRA and 2D time-of-flight MRA on a 1.5 Tesla scanner. All participants underwent standard of reference CTA within 60 days of consent or de novo as part of the study. The standard of reference CTA had to meet strict quality criteria. Both blinded and non-blinded reads of the CTAs and MRAs were performed. For the blinded read, there were 6 board-certified radiologists from a single academic institution, 3 evaluated the CTAs, and 3 evaluated the MRIs. For the non-blinded read, this was performed by a separate investigator at a core imaging facility. With respect to data interpretation, each renal artery was pre-segmented by trained technologists overseen by a physician at a core imaging laboratory. 3 segments were defined per renal artery as proximal, mid, and distal. Each segment was then evaluated for accessibility and the presence or absence of stenosis. For accessible stenotic segments, the degree of stenosis was calculated according to the following formula. Occluded segments were not considered clinically significant disease, as these are not treated. Here are the results. For the majority read, all of the primary efficacy endpoints were evaluated using the majority reader adjudication concept, wherein 2 out of 3 readers agree on a binary assessment. Standard of reference values were also based on the majority reader concept. All hypothesis tests were two-sided with an alpha of 0.05, and non-inferiority was assessed using a one-sided 95% confidence interval. In terms of accessibility, contrast-enhanced MRA demonstrated a statistically significant higher accessibility rate than time-of-flight MRA. Approximately 18% more segments were visible and therefore accessible with contrast-enhanced MRA as compared with 2D time-of-flight MRA. In terms of sensitivity, contrast-enhanced MRA was non-inferior to time-of-flight MRA for detection of clinically significant disease. There was a 7% greater sensitivity for the majority read and a 19% greater sensitivity for the investigator read. In terms of specificity, contrast-enhanced MRA was non-inferior to time-of-flight MRA for exclusion of clinically significant disease. There was a 9% greater specificity for the majority read and a 13% greater specificity for the investigator read. This chart demonstrates the clinical impact of accessibility. On the left, with contrast-enhanced MRA, more segments with positive disease were accessible than with time-of-flight MRA. On the right, with contrast-enhanced MRA, there were fewer non-accessible segments that were positive for disease. In this figure, we have an example of a case in which contrast-enhanced MRA performed better than time-of-flight MRA in detection of disease. This was a 63-year-old male with a history of hypertension, smoking, and diabetes. There was a moderate stenosis measuring 43%, which was seen on CTA, depicted in panel 1C. This was estimated at 47% on the contrast-enhanced MRA in panel 1A, but was not seen on the 2D time-of-flight MRA in panel 1B. This table demonstrates the mean artery diameter by modality for both stenosed and non-stenosed arteries. It calculates the measurement error for each type of MRA compared with the standard of reference CTA. This is depicted in the final two columns. Standard deviations are noted in parentheses. As you can see, for both stenosed and non-stenosed arteries, contrast-enhanced MRA measurements were closer than time-of-flight MRA to the standard of reference CTA measurement. With respect to the secondary endpoint of identifying accessory renal arteries, CTA identified 266 out of 1,752 arteries as accessory arteries. That's approximately 15%. By comparison, contrast-enhanced MRA identified 13%, whereas time-of-flight MRA identified only 3%. Here we have a case in which contrast-enhanced MRA outperformed 2D time-of-flight MRA in identification of an accessory renal artery. This was a 32-year-old female with a history of hypertension, smoking, and coronary artery disease. In panel 2C, on the CTA image, we can clearly see an accessory renal artery arising from the infrarenal abdominal aorta and supplying the inferior pole of the right kidney. This is also seen on the contrast-enhanced MRA image depicted in panel 2A, but is not seen in the time-of-flight MRA image depicted on panel 2B. With respect to the secondary objective of need for recommending additional imaging follow-up, an additional imaging study was recommended in 72% of participants using time-of-flight MRA, as opposed to 22% of participants using contrast-enhanced MRA. The most frequently recommended follow-up studies were contrast-enhanced MRA and CTA. In conclusion, contrast-enhanced MRA is non-inferior to time-of-flight MRA for detection of clinically significant renal artery stenosis. Contrast-enhanced MRA is superior to time-of-flight MRA for exclusion of clinically significant disease. Quantitative assessment of stenoses detected by contrast-enhanced MRA results in values comparable to CTA. Contrast-enhanced MRA is superior to time-of-flight MRA in identification of accessory renal arteries, which is critical for surgical planning. And contrast-enhanced MRA results in a 50% reduction in follow-up imaging exams as compared with time-of-flight MRA, potentially reducing patient costs. Thanks for listening. We invite you to read our full article in this month's issue of Journal of MRI.